Hello all, here's Pharm review for this year. We'll do it in two segments. So this is the first part. So in terms of item estimate is about 11% to 17%, 55 to 85 out of 500 items. Example from the website, which of the following preservative is most likely to disrupt corneal epithelium? And your answer would be a BAK. Which two of the following drugs inhibit synthesis of bacterial cell wall? And you need to select two here. So it's in cell wall, so it must be penicillin type related drug like amoxicillin, and also cephalosporin type of drugs, or cephalexin there, so B and E. So start with this category is schedule. So you have pregnancy category. Usually most of the drug we have in eye care is category C, and usually D and X you need to avoid using in woman having baby, pregnant woman. Okay, where as control substance you have schedule 1, which has no medical use. Schedule 2 have strong potential for abuse or addiction. Example, as you can see, the opium, morphine, and cocaine. And most of the drug that OD can prescribe is actually fall in schedule 3, 4, and 5. So start with pharmacokinetic. Basically is the AD, me, so it's absorption, distribution, metabolism, and elimination. Volume distribution, so this is dose per concentration of drug in the plasma. So usually if it is a lipid soluble or it is high protein bound type of drug, then it may have the large volume distribution. So to easily remember volume distribution is if a drug like just stay in the bloodstream, in the blood, usually it has a small volume of distribution. If it get out of blood and it start to distribute, like for instance staying in fat, staying in the bone, then it will have a large volume distribution. Clearance, so it's equal rate elimination over concentration of drug in the plasma, and the site for clearance is liver, kidney, lung, and other places. Even sweating also have some clearance. Half-life is 0.693 times volume distribution over clearance. So that's a formula you want to know, just in case if you need to calculate for a half-life. So 0.693 basically is equal natural log of 2. Bioavailability, so this is a fraction of drug absorbed into the circulation. So if a drug is administered by intravenous route, it has 100% bioavailability. If it is by oral route, then usually it's less than 100% because the drug needs to go to first pass through the GI digestion system and through metabolism by the liver. Bioequivalence in this case, so like for instance, sometimes you have generic drug versus brand name drug, and if the generic drug is equivalent to the brand name drug, then it has equal or close to equal bioavailability. So bioequivalent is kept in what you call an orange book in the FDA website. How many half-life to reach steady state concentration? And the answer, if you want like 90%, that would be 4 half-life, and if you want to go up to like for instance 96%, then you may need to have 5 half-life, and usually so 4 half-life is close enough to reach the steady state. Therapeutic index, this is the index of safety. So you have lethal dose of 50 over effective dose of 50. The larger the therapeutic index, the safer the drug, because you have a wider therapeutic window from the effective dose to a toxic dose. So you have zero elimination. In this case is that the enzyme that eliminating the drug is saturated, so it can only eliminate a constant amount per unit time. An example would be ethanol, phenytoin, and aspirin. So remember those three and you are safe for zero order elimination. The rest, most of it are linear, kind of more first order elimination, where the amount of drug is eliminated at a constant fraction per unit time. Phase 1 metabolism, remember there's three things happen: hydrolysis, oxidation, and reduction, and usually is done by cytochrome P450 in the smooth endoplasmic reticulum. Phase 2 metabolism is involved more of like transferring a bigger group onto the parent compound to make the parent compound more water soluble so that the body can get rid of the drug. And usually it's done through glucuronidation, sulfation, conjugation, and usually the enzyme involved in phase 2 reaction, it has kind of a transferase. So glutathione transferase or some other transferase in that case. Clinical trial, so you have different phases. Phase 1 clinical trial usually use healthy subject, and phase 2 then starting to test on small population of a patient, maybe 100 patients, and phase 3 now you get a larger group of patient, maybe 1,000 patients, and then phase 4 usually it's approved by the FDA and it's on the market, but then still FDA is still monitoring the drug, how is the drug doing in the market. First pass effect is when the drug taken by the mouth and go through the gastrointestinal tract and then biotransformed by the liver, like the phase 1 or phase 2 reaction. And the drug can go to phase 1 and then phase 2, or go to phase 2 first and go back to phase 1. The bottom line about transformation is to make the drug more polar to get out of body system. The volume of blood is about 5 liter, volume of plasma about 3 liter, and total body water is about 42 liter. So if a drug have a volume distribution about 40 liter, which means it's spread throughout the total body water, an example would be like alcohol. Most common plasma protein is albumin. Ion transport, there's different system. So in this case is for absorption of the drug. So you can have passive diffusion, facilitated, which means it's carried by a protein and transporter, so it is saturatable. Active, it means that it is actively pumped, so which mean that it can pump against the concentration gradient, so it is actually independent of concentration, so it can go from low to higher concentration. In terms of the urine, you can actually manipulate the pH of the urine to enhance elimination of drugs. So you can acidify the urine with ammonium chloride or vitamin C, and then you increase the elimination of base. So if you make urine more acid, you get rid more of the base. And if you make the urine basic, you get rid more of acidic drug. So as I just said, alkalinization usually done by sodium carbonate, and you increase the elimination of weak acid like aspirin and barbiturates. So we talk about P450 involved in phase 1 type of metabolism, and there's some chemical out there can induce P450. So like you have phenobarbital, nicotine, phenytoin, alcohol, they can actually induce P450. So what does that mean? If we induce P450, it means that it will increase the elimination of those drugs that metabolize by P450, which means if you give the patient a normal dose, it may not be enough to have the effective or therapeutic effect because a lot of drugs get metabolized faster. The other way around is that you may have agents that may inhibit P450, and those are known as erythromycin, ketoconazole, cimetidine, and omeprazole. So that's antibiotic, antifungal, antihistamine for inhibition of gastric secretion, and then omeprazole, which is the proton pump inhibitor. So in this case, it will actually slow down metabolism of drugs, so which means the patient may need to have a lower dose to minimize toxicity level. Constant amount of elimination I just mentioned, so those are phenytoin, ethanol, and aspirin. Hepatic cycling. So in this case, is that what happened is that you have a lipid soluble drug and get metabolized by the liver, but then it's still lipid soluble enough that it actually get through the bowel and get into the intestine, and actually it's still lipid soluble enough it get reabsorbed again by the intestine and go back to the liver again. So that's why you go through enteral, which is the intestine, and hepatic, which is liver. So it will go to another round of metabolism by the liver, which means that the half-life of the drug is longer because it can go through another cycle of the liver metabolism and stay in the body longer. Pharmacodynamic. So here's what does the drug do to the body. So this is more of the action of drug, usually via receptor. Okay, affinity is when the drug bind to the receptor, how strongly it bind to the receptor. The stronger the bond is, the higher in terms of affinity. Efficacy in this case is basically how well the drug produce a response. So can the drug produce 100% response? Potency, usually you're talking about potency when you talk about two drugs in the same class, and then you can say that drug A is more potent than drug B, assuming that both of them can reach efficacy. So usually when you design drug, you want to focus with efficacy first. Once you get efficacy, then if you have another member in the same class, then you can compare in terms of potency. For partial agonist and antagonist, as you can see, for it means that you have 100% effect. Partial agonist, which means bind to receptor, it can only have partial type of response between 0 to 100, for instance. Antagonist, which means that a drug bind to receptor, but then it does not produce any response. So when you have a competitive antagonist, which means it can bind to the receptor and then block the agonist from binding to the receptor, that way it can increase the KD, dissociation constant, whereas the non-competitive antagonist, it will not affect KD, but it will decrease the maximum velocity. Potentiation, in this case, so if, like, for instance, you have benzodiazepine barbiturate, those are CNS depressant, and if you kind of combine with alcohol, then there's a potentiation in terms of depression of the central nervous system, and patient can die from respiratory arrest in this case, so they cannot mix too well. Effective dose 50, lethal dose 50, so those that 50% of the population responds, either effective response or toxic response. Therapeutic index, I mentioned already, lethal dose 50 over effective dose 50. The wider the therapeutic index, the safer the drug. So narrow therapeutic index less than 3, as you can see, carbamazepine, digoxin, levothyroxine, lithium, phenytoin, theophylline, valproate, warfarin. Okay, here's just a few graphs. So competitive inhibition, as you can see, in the presence of competitive inhibitor, it will shift the curve to the right. Whereas in non-competitive inhibition, it will basically lower the Vmax, as you can see. So in the presence of non-competitive inhibitor, it lower the Vmax, as you can see there. So another way to plot those response curve, in this case is semi-log, and if you do double reciprocal plot like Lineweaver-Burke plot, then you will have a linear line. So in this case, as you can see, the slope is equal to Km over Vmax, and 1 over Vmax is at the x-intercept, and whereas minus 1 over Km is at the y-intercept. So that's a easier way to actually find the exact Vmax and find the exact Km. Another term that you may keep in mind is inverse agonists. So inverse agonists have opposite effect from those full agonists. They are not the same as antagonists, which block the effect of both agonists and inverse agonists. So inverse agonists, if you can think about this, is that at basal level for that receptor, a good example would be the GABA receptor. So at basal level, there's actually some basal activity, and the presence of an inverse agonist, it actually will lower the basal activity. So it's even lower than the basal activity. So that's why it's kind of an inverse agonist. So important bacterial pathogens, so this is for microbiology. So this is something that you can do a review for microbiology. So you have gram-positive, you have cocci and bacilli, and gram-negative, you have cocci and bacilli. So take a look at that and review for microbiology. Bacteriostatic and bactericidal. Bacteriostatic, basically, it was just stop the bacteria from growing. Bactericidal, it means that the drug can actually lyse the bacteria, kill the bacteria. So when you want to use bactericidal, so usually if the patient is immunocompromised and they don't have the immune system to clean up the static bacteria, then you want to use bactericidal. So in that case, you want to just lyse the bacteria and kill them. Post-antibiotic effect, it means that you use the antibiotic, even after you stop taking the antibiotic, there's actually still residual antibiotic effect. Example are the aminoglycoside like the tropomycin, neomycin, gentamicin, and fluoroquinolone like moxifloxacin, gadifloxacin. So sulfonamide, so in this case, actually work on folic acid synthesis. So in this case, bacteria need to synthesize folic acid in order for them to grow. So if you have sulfonamide antagonize the para-aminobenzoic acid, the PABA, then it will kill the bacteria. In human, we can take folic acid from supplement, and that's why we're not affected as much, and we have different pathway of making folic acid. Connectivitis is a toxicity of sulfonamide in a baby. So in this case, sulfonamide can actually displace bilirubin from albumin in a sense. So bilirubin high level can accumulate in the brain and can lead to jaundice, yellow baby. Trimethoprim is another class of drugs. It works at another step in terms of folic acid synthesis, and usually trimethoprim is combined with sulfamethoxazole in Bactrim and commonly used for urinary tract infection and other infection, or even of the eye. You may have toxoplasmosis that can be used with Bactrim. Prototype of fluoroquinolone, nalidixic acid, and it work on DNA gyrase, topoisomerase 2. The thing is that keep in mind, if younger patient or elderly patient on fluoroquinolone, they may have a higher risk of having tendinitis, tear, cartilage, or inflammation of the cartilage. Beta-lactam antibiotic, in this case it have beta-lactam ring, like penicillin, cephalosporin. Usually it inactivates transpeptidase, which is just important in synthesis of the bacterial cell wall. So since there are enzymes in the bacteria that can break down the beta-lactam ring, so the bacteria can be resistant to the penicillin and cephalosporin. So there's another class of drug called the beta-lactamase resistant. So here you have methicillin, naphthalene, oxacillin. Synergistic with penicillin, so here aminoglycoside, tobramycin or gentamicin. So in this case, aminoglycoside work on the protein synthesis, whereas the penicillin work on the cell membrane. So if they combine together, they work nicely with each other because the penicillin will penetrate the cell wall and allow for aminoglycoside to get in there and work on the protein synthesis. Ceftriaxone, ceffuroxime, and cefalexin. So those are the third generation, second generation, and fourth generation. So in this case, is that as you go from fourth generation to fourth generation, it covers more gram-negative. Aminoglycoside mechanism toxicity, in this case, so gentamicin, tobramycin usually work on the 30S ribosome involving initiation of the protein translation. The side effect to remember: nephrotoxicity, ototoxicity. So that's what you need to remember, especially for tobramycin, neomycin, and gentamicin. So the safest in this group is tobramycin. So nephrotoxicity and ototoxicity. Clindamycin, it's 50S ribosome, so involving translocation in translation process. In this case, the only thing you need to remember is pseudomembrane colitis, and this is a serious superinfection. Macrolide mechanism, like erythromycin, azithromycin, clarithromycin, are working on the 50S, the same thing, ribosome. Tetracycline mechanism, tetracycline, minocycline, doxycycline, 30S. So in this case, remember, kids younger than 8, you don't want to be on tetracycline because it can stain teeth, can interfere with bone growth. And also another thing is wear dark clothes to protect from sunlight because of photosensitivity. And another thing that may need to remember is sometimes it can actually induce intracranial pressure. Okay, tetracycline in kids, just mentioned already. Chloramphenicol toxicity. Chloramphenicol is not being used in North America because of aplastic anemia, and chloramphenicol is actually a good broad spectrum antibiotic that is still used in Asia, in Australia, but not in North America because we use other choice. So gray baby syndrome is something that can happen with chloramphenicol. It's because the baby's liver enzyme is not mature enough to metabolize the drug, and you have toxic accumulation. Antibiotic increases gastrointestinal motility. Interestingly, erythromycin can do that. So if you have a patient that have slow movement of GI tract, erythromycin can actually do that. Anti-TB drug, you have rifampin. Its unique thing is that the only RNA polymerase drug, and it can cause red-orange excretion in terms of urine. Isoniazid work on the microbacterial membrane synthesis, and isoniazid may cause neuropathy. So sometimes patients on isoniazid need to be taken with pyridoxine, which is vitamin B6, to help to reduce the toxicity. Ethambutol, this is something you need to keep in mind. It can cause optic neuritis. Okay, for the polyene antifungal ergosterol, you have amphotericin B. Usually, the phrotoxicity is the problem, and shake and bake. It means that when you deliver this drug by IV, it can actually cause chill and fever. So this is more for systemic type of fungal infection. Nystatin is the topical antifungal drop that you can use in terms of fungal keratitis. Azole antifungal, you have ketoconazole. It's available in shampoo, so you can use for like lice or some kind of scalp type of antifungal reaction. And gynecomastia, which means that it can cause men to have breast development. Metronidazole So ketoconazole can actually inhibit P450 as we said before, like the erythromycin also. Active only against dermatophytes. So in this case, if you have the fungal nail infection, you can use griseofulvin. This will disrupt the microtubule. Enzyme add phosphate to the acyclovir. So this is acyclovir. Usually it take advantage of the viral thymidine kinase, and basically, so you have phosphate group, and then it start to accumulate inside the cell with the viral thymidine kinase, and over time it will just lyse the cells, and that's how you try to kill the virus from multiplying. Prodrug of acyclovir is valacyclovir. Famciclovir is a prodrug of penciclovir. Ganciclovir, also phosphorylated, can complete with deoxy GTP. So this is GTP, guanosine triphosphate. So ganciclovir can work against herpes simplex, varicella simplex, and cytomegalovirus. So ganciclovir is usually used for IV if you have like CMV retinitis. Yeah, I'll just mention about that. Pyrophosphate analog inhibit DNA polymerase and reverse transcriptase. This includes phosgonate if you have a patient who is acyclovir resistant. Influenza A treatment, not B, amantadine, can block uncoating. And another thing that to keep in mind is amantadine is an anti-influenza A drug, but it can also be used in Parkinson patient by increasing dopamine. So this one is good for both influenza A and B. Oseltamivir or Tamiflu, it works on an enzyme called neuraminidase, and this is good for both strain A and B. Inhibit viral RNA polymerase, you have ribavirin, and it can be used for influenza and can be used for hepatitis C, pregnancy category X, so it's not for pregnant women. Nucleoside reverse transcriptase inhibitor, zidovudine, this is AZT. Amoebiasis, Giardia, trichomonas. So metronidazole inhibit protein synthesis and DNA strand breakage. Agent used for malaria coming up. So these are the Plasmodium, malaria, falciparum, vivax, ovale. So those are the agents that can cause malaria. So anti-malaria drug, the hydroxychloroquine and chloroquines. Remember, this drug can cause plaquenil toxicity or multiretinopathy. Pyrimethamine mechanism, plasmodial dihydrofolate reductase inhibitor. So in this case, this enzyme kind of for like folic acid synthesis. So this pyrimethamine can actually inhibit the folic acid synthesis in the malaria parasite. Disease may protect against malaria, sickle cell anemia, G6PD deficiency. Treatment of choice for toxoplasmosis gondii, pyrimethamine, and sulfadiazine. Humans get infected by toxoplasma via undercooked, infected meat, infected cats. Antihelmintic drug, periquintal, pyrantel, mebendazole, ivermectin, not on drug list. Antiplasmic, not on drug list. So you have 5-fluorouracil, mitomycin C, methotrexate, azathioprine, cyclophosphamide, and cisplatin. So just a few words about anti-neoplastic. So 5-fluorouracil and mitomycin C, sometimes used in eye care in terms when you do like filtering flap surgery in glaucoma. You can use 5-FU or mitomycin C to help to inhibit fibrosis or scarring of the flap, or it can be used in terms of you have pterygium surgery and that kind of inhibit the scarring or overgrowth of tissue, so they are kind of anti-metabolite. Methotrexate, it can be used for rheumatoid arthritis even though it is an anti-cancer drug. Azathioprine and cyclophosphamide, those are used more like anti-inflammation, so it's an immunosuppressant type of agent. Okay, let's stop here. We'll start next part with autonomic agent.